Right. Welcome everyone to UCLA Psychiatry Grand Rounds. We are really delighted today to welcome Dr. Ben Lee from the University of Rochester Medical Center. Dr. Lee is really a international leader in consultation-liaison psychiatry. He's a professor and chair of psychiatry at the University of Rochester Medical Center. And is also the editor-in-chief of our main CL journal, the Journal of the Academy of Consultation-Liaison Psychiatry. Before he was at the University of Rochester, he was also on faculty at Johns Hopkins and Yale, and he has built some of the most innovative models of integrated psychiatric care in the country, including the first proactive CL psychiatry model, which if you're not familiar with, we'll learn a lot about in his talk today. And has demonstrated with those models reductions in length of stay, time to psychiatry consultation, reduction in sitter utilization, and improvements in staff satisfaction, especially reducing nursing burnout and staff burnout generally. At the University of Rochester, I found this on your department's website. I love this, the Department of Permeable Boundaries. You have to tell us a little more about that. With psychiatry faculty embedded across many different medical and surgical settings, really serving the entire health system. His work addresses both quality of care and the mortality gap for individuals with serious mental health conditions. Really reshaping how we think about psychiatric care in general hospitals. We're also particularly grateful for his generosity in spending a lot of time with us here. So he was here with us all day yesterday, met with several faculty members, our fellows, with leadership, and his insights, warmth, and just wisdom and experience generally have been already enormously impactful, I would say. So we're honored to have you here, Dr. Lee. I'm looking forward to your Grand Rounds talk titled Transforming Psychiatric Care in General Hospitals, Advocacy for Severe Mental Illness and Cost Reduction Through Proactive CL Psychiatry. Thank you.
Thank you, Dr. Cruz, for the wonderful introduction. And I had a lovely time with Dr. Helena Hansen and Michael Gitlin and also Eric Chung. And thank you so much for welcoming me and making me feel home. I was here last time I was here was about 30 years ago as a residency applicant. And obviously a lot has changed, but my perspective as seeing psychiatry as a field of advocacy hasn't changed. And I'm going to talk about some of the work that I've done from the perspective of consultation liaison psychiatrist to really think about how can we effectively advocate for our patients by using the language of finance and administrative language to argue for the best quality of care for our patients. And to just give you some sense of where I'm from Rochester, and it's about 1 million residents live around the metropolitan area. And it's actually, Rochester is very far from the New York City. It's about 5 hours from the New York City, and we're actually a lot closer to Toronto. And also we cover a really big area, all the way from the Canadian border to all the way down to the Pennsylvania border. And we also have a Lake Ontario, which is only about 15 minutes away. So we do have beach. And our medical center, you can almost see that, or you can pretty much see in the slide right now on the below is our medical center and the medical school and the University of Rochester as well. It's a large clinical enterprise that consists of 8 hospitals that are spread across Western New York State. And it has an annual revenue of 6.5 billion per year, which is about half the size, I think, of the UCLA system. And our main activities from the Department of Psychiatry evolves around the flagship hospital of Strong Memorial Hospital. And we also have a children's hospital and cancer center, and also have a very large dental programs as well. In our case, we are it. Within about 100-mile radius, we are the only child psychiatry program and only emergency psychiatry program. Everything falls upon our scope. And we embrace that responsibility, and we very much love and care our community. And you'll see that that also reflected in some of my talk as well. Rochester, University of Rochester Medical Center is also known as the birthplace of biopsychosocial model. And George Engel, who developed biopsychosocial model, was actually a internist. He was a medical internist. And how it got started was around 1941. Uh, there was a very renowned physician, this Soma Wise, who's known for many terms like Mallory Weiss tear, the esophageal bleeding related to alcoholism. And he was in his 30s, actually, but he was already the physician in chief at the Peter Van Brigham Hospital. And he had this peculiar idea at the time of embedding a psychiatrist in the medicine unit and have them round with medical team. And that person was John Romano. And then there was and as he was rounding the medical team, George Engel was like a fellow. He was a graduate assistant. And he was very skeptical about having a psychiatrist in the medicine unit. But eventually, that skepticism turned into a respect. They formed a lifelong partnership, doing lots of important work in study of delirium. And eventually, they were recruited to University of Rochester to start the Department of Psychiatry. And there's also a story behind the start of Department of Psychiatry in around 1945. Helen Rivas was the heiress of the Jello fortune. Yeah. And she wanted to donate at that time huge amount of money, 3 point something million dollars, to build a cancer center. But William McCann, who was the department chair at the Strong Memorial Hospital, wanted to have a psychiatry department more than the cancer center. So he steered it toward it, and that's how they got recruited. And then that our psychiatry building that you see is still there. That's where my office is. And it began construction. And also Jules Engel, as he was recruited, started a consultation-liaison psychiatry service and fellowship at that time. So there's a lot of history around it. But overall, it's a department that's founded based on friendship between one internist and one psychiatrist and across the department as well. And out of that experience, George Engel developed the biopsychosocial model as he wrote this very seminal article called The Need for a New Medical Model, a Challenge for Biomedicine. And a biopsychosocial model, as you probably by know, it's regarding how we should view a patient holistically and make sure that we understand the complex interaction among biological, psychological, and social factors that relates to our patient care. What sounds like a common sense, but at the time when it was proposed, the rise of biomedicine and technology and all these scientific optimism was eroding the humanistic aspect of medicine in general. And that's why he developed it. And a lot has changed since then. Now, University of Rochester Medical Center Department of Psychiatry is a two campus, one at the original R building and the Brighton Health campus where we house most of our ambulatory care program, as well as four ambulatory care center that relates to our adult psychiatry in downtown and the pediatric ambulatory care center and geriatric and mental health center that also oversees all dementia care for the region, as well as collaborative care and wellness program that relates to consultation liaison and all our aspects related to working with another department. I'll tell you a little bit more about it later. And we got a lot bigger over the times, particularly in the last 8 years since I've been there. We now have about 200 faculty members. About half of them are non-psychiatrists, primarily psychologists. Also, we have a couple of economists and lawyers as well. And we oversee 2,000 staff. And our clinical program includes 90 psychiatric inpatient beds, adult and child. And we are also unique. I was talking to Eric about we're probably the only academic psychiatry department that runs an acute medicine unit. It's a med psych program. But the unique aspects of it is that we hire our nurses, clinicians, and we basically runs it out independently. And now our ambulatory care has grown to the degree that we now see almost close to 500,000 encounters per year. And we also have a pretty robust research program and also have a very busy training program that runs in many different disciplines, including residency, psychiatry residency, psychology training, and we have a really large marriage and family therapy training programs as well. So with that as a context, I talk to you about how we should think about the quality of medical care for patients with severe mental illness, especially in general hospital. And give you some background in terms of how we ended up developing this model called proactive consultation liaison psychiatry model, which began as something like $30,000, $40,000 small QI project at the Yale New Haven Hospital. This is like around 2010. And then a contrast between the reactive, the conventional model of consultation liaison psychiatry and the proactive consultation psychiatry model that we continue to develop. And I mentioned a little bit more about the MedPsych unit at the University of Rochester and the emerging evidence, probably now established evidence for reduction in length of stay, cost of care, and staff and physician satisfaction in taking care of people with severe mental illness in the medical hospital. But keep in mind that it's all related to how we should view psychiatry as a field of advocacy for our patients. We just want to be able to use the language, use the ways that we can convince administrators and finance directors to be able to reach that goal. And I mentioned the Rochester model with global support for the general hospital as well. Just a quick idea. We spend about $5 trillion on healthcare in the United States. And that's a lot of money. That's a lot of money because per person GDP that we spend is about twice as much as any other countries as well. And the other interesting thing is that we spend about 18% of our GDP on healthcare, which is twice more than any other westernized countries in the world. And we are completely an outlier. And people wonder, why is it that all our people with desperate, homeless, and hungry people come to our emergency department? Because hospital, our healthcare system, is where the resources are. That's why they are coming here, because we spend all our money there. And the biggest cost center related to our $5 trillion cost of healthcare is the hospital. It's how much we spend. 1.6 trillion of the 4.7 trillion in 2023 is spent on hospital cost. So the question is, how do we reduce it if we want to reduce the overall healthcare system? And that's, everybody knows, it's a very basic idea. You can reduce it by trying to make every hospitalization count by reducing readmission, reducing the episode of care by the length of stay, which becomes a bit more important as I talk about it, and cost of care per episode during the hospitalization, and move the medical care closer, use more outpatient care, right? I mean, to more preventive care as well and avoid hospitalization. And also focus more on the transition of the care from the inpatient, outpatient, and vice versa. And take the cost out of the healthcare system by utilizing or developing, in our case, more social services for our patients who are often very vulnerable and homeless and hungry as well. It is also very well known. People with comorbid psychiatric diagnosis have a higher total cost of the care per month than those who are without psychiatric comorbidity. It's also very well known. Most of those costs are not related to psychiatric care. It's actually primarily related to diabetes, heart disease, and surgeries, and etc. Especially as you get older, the left is a Medicare spending per patient with or without mental health disorder, and to the right is the commercial insurance pay. And I think some of these data is actually from California, by the way. And where I'm from, New York State, also, this is a big issue right now. New York State has about 7.3 million beneficiary of people with Medicaid, which is about $84 billion per year in terms of, I'm sure it's been grown. Now, out of them, about 20% of them uses 80% of the entire $84 billion. Now, of them, about 60% of them has a comorbid psychiatric disorders. So it's very easy to think that this is where the cost reduction should happen. And a lot of times, the 20% of the patients who are being discharged from general hospitals are readmitted within 30 days. And avoidable cost is thought to be about $800 to $1 billion. And 70% of these readmission happens with patients with comorbid psychiatric disorder. In other words, if you are able to save money, if you're able to reduce the cost related to medical care of patients with psychiatric conditions, you should be able to make a curve, this curve related to it. But having said all of this, none of us went to medical school, nursing school, graduate schools to reduce cost. The most heartbreaking and most important data, as far as I'm concerned, is the mortality gap that we have in our community. I believe that people with severe mental illness represents the most vulnerable sector of our community. And it has been replicated many, many times that people with severe mental illness live 10 to 25 years less than those people without. And it doesn't matter if you live in the United States or other countries. And standard mortality ratio is almost ridiculous in relation to a variety of medical conditions. And that has grown over the last 3 decades. That gap has grown. And most of this mortality gap is explained not by suicides, not by psychiatric issues, but primarily related to what we can intervene, related to cardiovascular disease, infectious disease, cancers, pulmonary disease, because they smoke way too much. And one of the interesting study that was done in Oregon is that if you have both severe mental illness and substance abuse, your life expectancy is as little as 45 in the United States. That's just unbelievable. But how do you then advocate people with severe mental illness to get better medical care? That's also very obvious what we should do, right? I mean, we need to find a way to deliver better primary care and help them have a better, healthier lifestyle, smoking cessation, alcohols, and etc. Early diagnosis, address some of their social determinants, and etc. And also, when they come into the hospital, we try to do our best to provide the maximum inpatient general medical care as well, right? And that's the role that I believe is the role that CL psychiatrists should have in terms of advocating for our patients. And also, we also need to work on care transition issue between inpatient to outpatient to the emergency department. We need some kind of wraparound service for them. Eventually, we do need a value-based care for these particular group of patients. And but why is it so hard to advocate for them? Well, because we have a very divided healthcare system. And I understand that you're in the process of moving psychiatric hospital out of here into suburban area. And it has its own rationale. But the reality is that we have NIH, we have NIMH, you know, there is a big gap between psychiatric services and medical services. And the role of consultation liaison psychiatry is to try to be able to build a bridge between them. And now, as we think about consultation liaison psychiatry, if you think about the particular model, it's a model that began in 1940s actually, and it's very outdated. And the idea, it does work to a degree. I mean, the idea is that as the medical team or surgical team or whoever is there, as they identify psychiatric issues, quite often crisis, they call or they place consultation request, and the psychiatrist sweeps in and be able to address some of those issues after evaluation. And then, they also support the service work, the nursing staff. There's a liaison aspect. We also try to do our best to educate the team as well. So let's think about a simple case that Dr. Cruz and the CL team often encounter. 50-year-old man with schizophrenia, okay, smokes, has hypertension, cholesterol, high cholesterol, obesity, and has some diabetes, and he's somewhat paranoid at baseline and has some auditory hallucination that's ongoing. Okay, he's admitted through emergency department with chest pain, and he has an unstable angina. And it's obvious that the typical thing to do is go through the cardiac catheterization and go into angioplasty and CABGs after admissions and etc. But it's later different in patients with severe mental illness. It's very stressful for the patients. And in the middle of all these, like in ambulances, etc., he has missed a couple of the home medication that he was taking. Sometimes he was not taking, and at the same time, it's hard to track what he was on, and so eventually he becomes increasingly more paranoid and agitated in the unit. And then let's say he gets into arguments with young nurses who just started her first job in the inpatient medicine unit, along with the hospitalists and residents, and gets into this awkward situation. And then let's say he swings at the nurse, and then in the middle of all this starts refusing cardiac cath and starts demanding discharge against medical advice. Okay, it's not uncommon study. This is something that we see almost every couple of weeks or daily or sometimes, and then the patient is fully psychotic, and eventually this consultation liaison psychiatry request is finally made. We have a patient who is psychotic, agitated. Can you come and help us out? And then it's like consultation liaison psychiatry team sweeps in, and then we try to adjust the medication, and patient is agitated. We put a companion and a sitter in some of the places, and to try to do it. But right now, patient is not listening to you, so we try to get some sort of a hold, temporary conservatory SIPs or something like that. In the middle of this, cardiac cath is postponed, and the medical team is starting to think maybe we can get by without cardiac cath. And they talk about how we can do this perhaps by maximum medical therapy. And then in the middle of this, they make bed requests. Beds are full. Patient is stranded in the medicine unit for days. Insurance company denied the reimbursement, and in the middle of this, the nurses are angry because they're not transferring the patients. the hospital is angry because the bed's occupied and your ED is now fully boarding patients to another patient. So a lot of cost to everybody. There is a cost to the hospital. For those who do not know, every episode related to one diagnostic code means the same regardless if you stay 3 days or if you stay 2 weeks. The longer length of stay means less patient that you can take care of, less revenue for the hospital. Constant companion related to it costs money. There is a use of restraint that also is expensive, higher cost of care, denied days, all is a problem. And it's also very challenging to the medical and nursing staff who is worried about their wellness, the burnout rates, and turnover rate of this staff is also very much a problem. And also there's a risk to the staff and the patient as well in relation to potential violence in the unit. It's a number one concern of every medical unit around the country in relation to all these hospitals. But most important of all, though, we have a patient who should have gotten cardiac cath and angioplasty quickly, who now has a compromised medical care, along with a very terrifying experience for the patient and interruption in his or her life. And this is repeated many, many times in the variety of. This is an article that was published in JAMA by someone named Ben Druss and Emory. And he did this wonderful study, analysis of pretty large data set that shows that how patients with psychiatric condition are about 50%, see the relative risk of 0.55, in terms of getting cardiac catheterization and revascularization, 70% less. It's worse than that, I thought. In terms of actually getting a cardiac surgery for the same diagnostic code. It runs, in fact, in every diagnostic codes as well. And particularly, though, ones with severe mental illness in relation to people without mental disorder versus with mental disorders. That article was published in 2000. And has that gotten better? Not quite. All the meta-analysis now, because there's been so many studies that have shown, confirm that people with severe mental illness continue to get suboptimal care related to heart disease, particularly myocardial infarction. People with schizophrenia only receive about 50% of the cardiac procedure rate, according to the more recent meta-analysis. And basically, their survival is also, mortality goes up by another 40% for 1 year, as well as 30% in 30 days as well. So there is a tremendous cost related to this missed opportunity to provide the best care possible for our patients. But it's not just the cardiac care. As a consultation liaison psychiatrist, we often see this suboptimal care in the general medicine unit. It's only ironic quite often that people with severe mental illness who comes in for a variety of acute medical issues are usually placed a bit far away from the nursing station. And the nursing, but at the same time, the quality measures done by Gail Dowman at Hopkins have also demonstrated the quality of medical care seems to be lower for people with severe mental illness, as well as lots of mistakes are made at a much more frequent basis. 5.8 events, patient safety events per hospitalization, along with many of them 42% higher than others in relation to those with physical harm as well. So the quality of care also suffers as well. So why is it that we continue to consult or we help out these patients only after certain crises happen? Why is it that it's always these requests are related to, reaction to crisis. Why don't we actually do it from the beginning so that instead of at the end, we can find a way to get involved earlier in the care and then being able to guide them through this hospitalization so that their episode of care is done more cost effectively, but more importantly, with better quality of the care and be able to help them obtain cath and angioplasty and discharged home in time. So that idea was first started by William Sledge, who hired me in 2011 at the Yale New Haven Hospital. And the way that it got started was basically because of this particular regulatory citation that they received because we were doing a very poor care for psychiatric patients in medicine unit. And Yale New Haven Hospital, New Haven is a small city with big city problems. Lots of substance abuse, lots of issues, and poor psychiatric resources. And there was high comorbidity rates and lots of violence and lots of staff complaints and they were using something like 55 FTE for constant companions related to all this and lots of delay and etc. So there was a lot of issues. So he decided to do a small pilot at that time. And the idea was very simple. With small amount of funding, let's just have a psychiatrist round with a medical team for 30 days. We're going to measure the length of stay for that particular unit with very high psychiatric comorbidity. And I'm sure you have one as well in the Reagan Hospital as well. And it'll be an ABA design. We'll place the psychiatrist around with and then provide consultation as in this case, Paula Zimbrian was the consultation liaison psychiatrist, and provide consultation on the spot. And then we'll do that for 33 days. We'll have a control group of a variety of places. And then we'll take away the psychiatrist to see what does that do, right? So ABA design, And what they found, it's a one article that we published in 2011, I think. And it's basically, it reduced the length of stay by substantial amount, 0.9 days. And for those who do not know what that means, about 1 day in hospitalization for the medical center is about, in the general medicine, about $2,000 also, at least at that time. So it was really interesting to the hospital administration to see this particular data. And, obviously the consultation was done really quickly, 1.4 days, because on the weekend we didn't provide that kind of thing. Now, consultation rate did go up about twice more. And that's one of the lessons that we learned. And as I talked about, this reduction in length of stay, also the variability of the length of stay was another thing that we reduced. And see how we reduce the length of stay from the before and after during the intervention time. And then once we took away the psychiatrist, it popped back up. And that was basically the idea of doing this. So we learned some lesson from this simple, very inexpensive QI. One is that, remember how the CL consultation rate went up when psychiatrists identified it? So we think the CL service is underutilized. And embedding a psychiatrist leads to better case identification. And by having this more of a proactive consultation provides more wide and broader, and more importantly, earlier coverage of these psychiatric issues that led to less length of stay. But the other thing that was really gratifying for the team was that nurses loved it. The hospitalists really loved it. And so we had a response. The hospital administration said, well, why don't you then do a more robust pilot to cover 3 units this time for 1 year. There was a half the medicine units. Now when we scale it to a larger team, we had a couple of issues. How do we scale this? Because we cannot hire psychiatrists for every one of these units. Second thing is, over the time, we also noticed there are lots of psychosocial issues. There are things, though, you can do better with psychiatric nurse practitioners. You can do better with social workers, and you can be probably more cost effective by creating more of a multidisciplinary team to cover a broader areas. And that's the idea behind developing a multidisciplinary team. So around that time, I was working on this, developing this model, and basic definition of what we at the time called behavioral intervention team was proactive, multidisciplinary team that identifies and removes behavioral barriers that interfere with quality and efficiency of medical surgical care. And the goal was relatively straightforward. We'll screen based on the patient's admission notes, based on the nursing interaction, and assess and intervene in order to remove any barriers that relates to quality medical care in the hospital, and also at the same time advocate for the patients with severe mental illness. So what is it different? Well, it's a proactive. It's no longer reactive to crisis. The goal is to prevent crisis. And the personnel is obviously different. It's no longer a single discipline, it's a multidiscipline. And the case identification is not based on the consultation request, it's based on records and based on the nursing staff interaction. And we provide advice not only to the team, but also to overall nurses and social workers, and provide more of a collaborative care. And the service goal, as I mentioned, is more about prevention of behavioral barriers and the crisis. And the location is also very different. Instead of trying to cover the whole hospital, the team simply focused a defined geographic area where we know who's coming in and who's coming out. That's the idea behind it. So in a way, it's a population health in a very small scale. And eventually, we published this study in psychotherapy and psychosomatics. We did manage to reduce 0.64 days in terms of average length of stay for those with psychiatric comorbidities. And we also demonstrated that the constant companion use was reduced overall about 8.7%, particularly in relation to suicide-related, behavioral-related constant companion use. We didn't make a dent, actually, though, on the 30-day readmission. This was done at the time when we didn't quite think about the readmission, but we did calculate it. It was slightly lower, but it didn't make a dent, by the way. But some other studies have done. We also measured some aspect of staff satisfaction. It was the nurses who are very enthusiastic, and the hospitalists who are also very enthusiastic. We didn't use any scale, but that's something that we have observed. The cost and benefit of this was actually published. Now, we didn't do this paper. It was actually the Janice Bozo, who was the finance director for the Yale New Haven Hospital. Yale New Haven Hospital is, I've always looked at it as a kind of peculiar place. They have more MBAs than physicians. And they really scrutinized this particular study, and they somehow published it in this obscure journal. And what they found is that compared to the money, the salary cost, that was about $400,000, that through variety of sources of revenue, the cost per case differences, reduction of the constant companion, as well as the revenue backfill, because you were able to reduce the length of stay and be able to take care of more patients. The net gain was calculated to be about $1 million, and the difference was $640,000 at that time. Now, if you notice it, it didn't include any billing by the consultation liaison psychiatrist, whatever. But we decided to simply ignore it because it wasn't that big of a lot of money. But what we are interested in is the save cost, as much as possible in terms of doing it. So of course, like after looking at that, it was very important that we wanted to make sure our metrics are developed by our finance administrators rather than by us in relation to this. It's a pre-proposed metrics that we were working on. It expanded to entire 8 medicine units at the York campus. Eventually, it expanded to the St. Raphael campus as well. Eventually, it also covers the cancer center as well. Eventually, many hospitals, as we published more data, started to learn from us in terms of how we do it. Johns Hopkins, Dartmouth, Stony Brooks, and many hospitals, small and big, have adopted it, and we stopped counting at the different. And if you go to the ACLP meeting, there is a proactive psychiatry SIG group that has about 500 people working on this, and there's lots of resources in the unit. We made Wall Street Journal, my 15 minutes of fame. And then our length of stay reduction, as well as the cost of care, was replicated at the Stony Brook University. They did actually a bit better, 1.6-day reduction, along with this idea of net direct contribution margin of $300,000. Interestingly, that as the time passed, as people were more and more interested in burnouts and wellness and nursing turnovers and hospitalist burnouts, people began to focus more on other aspects as well. And this is the Johns Hopkins team with Pat Triplett, who is still leading that team. And they also showed length of stay reduction. But what they were also interested in was actually doing in a more structured way is related to nursing satisfaction. Before and after, red is bad, green is good. So you can see the differences. And the University of Rochester, when I moved over to Rochester from Yale in 2017, of course, we started this as well. Now we cover the entire medicine units. And we also demonstrated length of stay reduction. But interestingly enough, in our case, we also measured the burnout rates of the hospitalists as well. We showed all of the aspects of the provider satisfaction was improving before and after, but we also saw improvement in terms of burnout scales by the hospitalists as well. We did see the improvement in terms of the nursing satisfaction. We actually didn't see the burnout scale improvement for the nurses, but it's probably because during the daytime, we were providing it, nighttime nurses weren't really affected by our lack of presence. So we think that's probably it. But overall, they were also very much satisfied by the additional resources. And the nursing attrition also decreased as well, which was very important. Many of these studies are now done. There are systematic reviews, a couple of them now, demonstrates that the length of stay related to a proactive consultation model is very much replicable. The ones that didn't show are the ones that used scales. Apparently, it's very important to have a psychiatrist or nurses or social worker are the ones who identify the cases and then be able to rate them in terms of who needs to go where. The severity of case and how you divide up the team is really, if you use the one single scale to do that, it's very difficult. Eventually, American Psychiatric Association got together and developed this resource plan. And that was published a few years ago as an alternative model to traditional consultation liaison model. And can it be done in smaller hospital? And there are small hospitals with 32 beds. And Joe Kugler, one of my former fellow, was able to demonstrate that can be done in a smaller community hospital. And also Children's Hospital also was able to demonstrate the utility of this proactive model in the hospital. I was just talking to one of the psychologist members of the CR team, and it's something that certainly can be done in the hospital in terms of length of stay and be able to do more for our kids. Can you do this outside of general hospital, general medicine unit? So some people are now beginning to look at that. And I recently saw a paper that was published out of the obstetrics unit at the University of Colorado Medical Center. It increased the consult rate, but it was also a very well received by the staff. I don't know what the length of stay reduction was. And at the ACLP meeting, we're going to have a Mayo team, a Mayo Clinic team, and our own Rochester team get together and really look at how we are doing, because we got very interested in cardiovascular units. Remember, the daily rate for the general medicine unit is about 2,000 per day. For the cardiovascular unit, it's about 3 times as much. In other words, if you can reduce it by 0.2, you can more than make up for anything. And interestingly, eventually, people in England got very interested. So Michael Schaub, one of my good friends at Oxford, did a randomized controlled trial. It's a huge study with 3,000 participants. But it's a very different trial. He actually, the mean age was 82 years old. And mean MoCA score, the dementia score, 24 is the usual cutoff, was also, I think, about 18, I think. And they are recruited and randomized to usual care or the usual care plus this proactive integrated consultation model, a bit different than what we did. And primary outcome was again related to length of stay and placing them, discharging them home, and etc. And this was published in Lancet just a while ago. And it was actually a negative study, although they reduced it by 0.45 days, but there was so much variability they didn't. It's probably the only negative study that Michael has ever conducted. Rate of discharge to home was a bit higher, and there was really interesting mortality advantage related to this study group, proactive CR group. And I think that's probably related to advocacy more than anything. But that's my and this is continued to get published in many different places. Around that time, I also saw a study out of a country in Europe, and I was very touched by that. It was done in Ukraine. It was published in the middle of Russian invasion of Ukraine. And she and I communicated. This was presented at European College of Society of Psychosomatic Medicine, and a very simple study with lots of methodological issues, but it was really interesting. Can you do even better? Well, one of the reasons as to why I moved to University of Rochester was this idea of, can psychiatry department run medicine unit? And we do have a medicine unit, and that was fascinating and interesting. And so we have a medicine and psychiatry division with internists and family medicine doctors in our faculty. And it's very unique. We have 20 beds devoted to severe mental illness, 10 beds related to substance abuse, and we continue to expand that beds. Does it work? We have demonstrated length of stay reduction as well as readmission rate. I'm just going to go really quickly because I think I'm beginning to run out of time. And recently we published another article related to what particular condition is it most effective. It turned out people with mood disorder and suicidal ideation have a lot more length of stay reduction and discharge to home than other diagnostic groups, which was interesting. We don't do that well with dementia patients, by the way, because once they are here and waiting for the nursing home placement, it's totally out of our hands. Out of that, at Rochester, we are looking at global support in relation to the hospitals. So those with high psychiatric complexity and severity with acute medical issues, our MedPsych unit. The moderate psychiatric severity, we do proactive consultation. And then the rest of it in OBGYN surgeries and other places, we do traditional. So more of a combined model to support the total hospital is what we are working on. And true to it was actually John Romano who talked about a department of permeable boundary. It's not my own quotation. Who was the first chair. And now we have 50 psychiatry faculty members spread out across the board. There's no department that does not collaborate with us clinically, other than maybe radiation oncology and pathology. And we are working on that too. The latest one is the ophthalmology that we are working on developing behavioral program for blindness and the low vision as well. And so the dream of Semel, who died young, by the way, in the early 40s, was to hire a psychiatrist and embed in this medicine unit. And George Engel, they worked together. And eventually they developed this vision for Department of Psychiatry. And that's the path that our department is following. So just to summarize, I think you pretty much get the whole idea. People with severe mental illness die young, and our job is to advocate for them through what we think is the consultation-liaison psychiatry. By the way, I don't believe the model that I developed is the best and only model. What I'm encouraging you to really think about, what are other ways of advocating for, and let's test it out. What is that way we have innovation? Why is it that we are stuck in 1940s model for so long? And overall, we demonstrated by length of stay reduction, but ultimately it's the advocacy for these patients that's really important. And the MedPsych unit is really interesting to me these days. And at Rochester, we are trying to combine them all so that we can effectively advocate for our patient in all areas of the hospital. David Satcher, who was also a resident at the University of Rochester, talks about there's no health without mental health. Our department believes that there's no mental health without physical health. So on that note, I wanted to thank everybody for inviting me and making me feel so much at home. And so thank you very much.
Thank you so much, Dr. Lee. I'm wondering if at first we have any questions from the audience, and I'll take a look here at our Q&A too, if I can find that. Dr. Hansen.
Dr. Lee, that was incredibly compelling and also very timely for us. As you know, we're moving to mid Los Angeles, so we'll have a freestanding psychiatric hospital, making the questions about CL coverage here even more acute. But even before that, thanks to Dr. Cruz and others, there was a real focus on overhauling our approach to CL psychiatry. And you began to share this with me last night, but I know you have some insights about what motivates institutional change. In your travel to many different medical centers that are equally captivated by your model, what have you seen are some of the most compelling arguments or experiences maybe that medical center administrators have that would motivate them to look at this proactive CL model?
Yeah, and at the heart of it all is really reminding ourselves as to why we became a doctor, nurses, and psychologists, and why we chose psychiatry. And with that as the fundamental value that we have, it does seem to me that every hospital, when they adopt this model, have a different motivation. For example, when I visited Vanderbilt and gave a similar talk, they were very focused on nursing turnover. And from the top down, that was the biggest issue that motivated them to do the proactive model. At Yale, it was all about finance. So we utilized that language to be able to demonstrate a pilot. There are also other places related to patient quality index, and there are also other places that also thought that this is also a simpler model, larger staff, but at the same time more expedient model related to cost saving, related to personnel as well. So what's important, as I was talking to everybody, is that you always want to begin by having some kind of demonstration project, a small, scalable demonstration project that your personnel and the hospital personnel agree on metrics of importance. That is different from one place to another. And then you agree on how you're going to be able to measure it and be able to do this kind of, and then you also are willing to step away from it if it's negative. And I think that's but knowing your wonderful committed team and everyone involved, I'm totally confident it'll be a positive. I've never seen, I mean, many hospitals have done pilot studies related to it, and Vanderbilt is doing I think they're actually doing a clinical trial related to it. And all of them have been positive. And so, yeah, so that's how we do. And we'll be happy to help out.
Thank you.
Yeah. Oh, there's
Hi there, thanks so much. I felt like I couldn't take enough notes, so thank you. I'm a psychologist in our PCL service. This is our small but mighty CL service here. I wanted to ask something because as I was listening to your talk, there's some similarities within proactive CL psychiatry and what's sort of going on with the palliative care models as well, where there's kind of a push for palliative care to be involved sooner, reducing costs, reducing suffering, these types of initiatives. And I've just noticed kind of more anecdotally with palliative care, there's needed to be a bit of a rebranding and education around what palliative care physicians do and what palliative care teams offer, and that they're not simply just kind of death and end of life. Do you find that there's a bit of a rebranding or a bit of an education that needs to happen with systems around what psychiatrists, what mental health providers can do or what they can do, especially in the proactive space?
that's an excellent question. It's one of those, it was really interesting. In the beginning days of the proactive model, we even had debates between people who really believe in traditional model versus people who wants to bring these changes as well in terms of what is the role of consultation liaison psychiatry. There are people who believe that consultation liaison psychiatry should be a higher level of expert who renders expert opinion about the best care of this particular patient. I have viewed consultation liaison psychiatrist's role as being able to be more patient-centric. So the traditional model is more physician-centric in that sense. Our job is to refine the question that's consultation liaison consultation is done and being able to address it to our colleague from a physician to physician. From my perspective, it should be patient-focused. We identify what the issues are in patient in relation to receiving the best quality care and be able to provide psychiatric support and liaise with the overall team, the medical team that consists of social worker, nurses, and physicians. So there's some role that had to be worked out, and that was some of the differences. Now, some of these ideas you said is palliative care has worked on it probably even before than I did. And the other places that I worked on it even before than we did was in orthopedic surgery with hip fractures, with developing geriatric medicine consultation very early from the get-go. And so in reality, what we have done, what I have done is not really innovative. The idea of delivering behavioral health service earlier is something that was done even in the time of, John Romano, right? The only thing that we have done is to develop a structured model and be able to measure what we have done carefully along with our administrative leadership so that we can disseminate it. And what I was struck by is that your CL team has a very innovative and also have a research background. You have all the right personnel to be able to do something very innovative and field defining kind of newer, even better model than what we have done, and in our hope to improve the overall healthcare of our patients.
There was one question in the Q&A about delirium prevention or outcomes generally, if that was ever evaluated in the proactive models.
Yeah, not in our study. We didn't look at it. Now, if you look at the picture, that's Mark Oldham, who was my fellow, who is also now a president of American Delirium Society. Without a lot of his work, many of these things was not disseminated. And Mark is currently working on some of these initiatives at University of Rochester in terms of preventing delirium, but not out of this particular behavioral health role. It's more of a global issue in relation to how we screen patients through our EMR and intervening, reducing extra medicines and those kind of things. Having said that, our surgeons are really interested in what we are doing because they do see the need for being able to guide our patients with psychiatric comorbidity through their back surgery and cardiac surgeries and other surgeries to be able to reduce their post-operative complications and returns and etc. And if you look at like some of the data that we also published a while ago, is that, for example, pulmonary lobectomy. Patients with severe mental illness, their mortality is about 4 times higher in the hospital than those without. Why? Simply because they don't really do as much in terms of following the nursing guidance, the usual, the pulmonary toileting and all those things. You really need somebody to really guide them through this post-op care. And that's what we are now starting to work on the next 2 years, as we now have gotten some funding to do that from the hospital.
I have another kind of comment and question kind of around the culture of care and how this model seems to shift things. My mother, during a hospitalization a couple of months ago, I was chatting with her surgeon here at UCLA about, what I do, what he does, et cetera. And he was kind of laughing. He says, we actually consulted psychiatry on a case on our service currently. He goes, we don't know yet if they're going to come, but we were placing bets in terms of whether or not psychiatry would come see the patient. And that's not great to hear. Right? And obviously there are a lot of reasons for that with limited bandwidth, et cetera. And this sounds so like transformative potentially in terms of the relationship with psychiatry. And I just didn't know if you have wanted to comment or were able to comment on that at all.
At heart, we have to. We believe that every surgeon, every medical doctors, every pediatricians care about their patients to get the best care available. And more often than not, we always have our own stereotype about what surgeons are like and what cardiologists are like and etc. But when it comes down to it, I have never met a physician, nurse, or psychologist or nurse practitioners who did not care about their patients. Ultimately, what happens is that they do want to get better behavioral health support. They just don't know how to. And they don't know what to ask about. And they are often wondering if their questions are even valid about their patient care. They worry that their consultation requests would be laughed at sometimes. And often they do make strange requests, right? But the reality is that the question then is, what is our role? I think, overall the leadership, its job, administrative leaders, CR directors, and hospital, this the clinical vice chairs, etc. Our job is to translate these needs in the way of terms that administrators and financiers understand. And length of stay was our attempt to translate what is the right thing to do into the terms that they understand. And it could be a nursing turnover in another place. It could be patient satisfaction in another place related to who knows, right? I mean, so, but those are the opportunities that we all have to kind of look for in being able to advocate for our patients. Yeah.
Hi, Jennifer. So I have a question more about sort of integrating teams, because I think my trainees will say I'm always harping more on liaison than consult, because I think understanding the team cultures and the physicians and just like the health system structure is so important. But I have an example. So although I'm a pediatric psychologist, I spend time on the adult cystic fibrosis team.
Mm-hmm.
And so in that team, we have 2 psychologists that then get to know the patients really, really well. And once they're admitted, you can help the ICU and the pulmonologist kind of manage the patients. And so that's a little bit separate than kind of CL psychology, CL psychiatry and psychology. But is there any research as to the utility of having a dedicated mental health provider within these teams that then can support both outpatient and inpatient versus a standalone consulting team that maybe doesn't know as much about the illness and the intersection with medical illness, or doesn't know the patients? Because I found working, with the 3 ICU doctors that I know, that they've grown in their understanding of what psychology can do, but then they also really, when they're not sure if there's an appropriate question, like the surgeon, they like to be able to bounce things off us.
Yeah.
We know these patients longitudinally. Some of these patients I've known now for like 5 years, so I know how they're going to adjust to a hospitalization. I know what the issues are going to be, but I don't know if there's cost saving comparison between integrated versus just CL alone.
Yeah, I think embedding someone into the place that they are working is very important. By the way, I also used to have a clinic in the adult cystic fibrosis program at Yale, and Cystic Fibrosis Foundation funded many of these places, and I was that person. But so I'm familiar with that. And what a wonderful group of cystic fibrosis also advocates. There's just my heart goes out to them. The idea of this particular model is exactly what you're talking about. When you are, like, let's say, working in, I don't know, some OBGYN floor, and you're placing a consultation, and you have someone coming in for the first time, you're meeting them for the first time, and you're not exactly sure who this person is, and you're not exactly sure what kind of training, what kind of expertise. It's particularly more so in the surgeons, by the way, because often surgeons think that the psychiatrists don't really understand the surgical clinical pathway. So there's some skepticism already involved, by the way. But the way that we approached it, in the proactive model, that this embedded psychiatrists and nurse practitioners and social workers, and it could be even psychologists, are part of the overall team. You're working with them in the same geographically defined area, day in and day out, shoulder to shoulder. You're bouncing off different ideas. You're chatting about your kid in, I don't know, in piano recitals. There's an inherent increase in terms of level of trust that you develop. Now, we never really looked at what % of our recommendations are accepted by the primary team, but I suspect it's much higher when you're working in the proactive consultation model, because you're there, your colleagues. We go to our, I don't know, like birthday parties together, and that's why I think also people find this particular model very gratifying. There's no awkward moment in relation to introducing yourself to the consultant, defining what the issues are, because you already know. And so there is some advantage, clear advantage of why this might work.
I want to thank you for coming, Dr. Lee. For those of you in the room, we do have the room available for some ongoing discussion. And thanks to everyone on the Zoom for joining. And again, thank you, Dr. Lee.
Thank you. Thank you so much.